Today's topic is going to be how often should you receive MRD testing while in remission? And Dr. Richter has actually prepared a great presentation to give an overview of minimal residual disease, or MRD, and then kind of delve into the questions that MRD brings up. And as I mentioned, it's one of the most debated and discussed topics in the myeloma community events. And there are varying opinions between specialists on whether or not the testing should be done, what the results should be used for, and how often that testing should be administered. So here to speak to us today on the subject of MRD is Dr. Joshua Richter, and we're excited to hear his opinion on the subject. It's my pleasure to introduce him to you. Joshua Richter, MD, is Associate Professor of Medicine in the Tisch Cancer Institute Division of Hematology and Medical Oncology. He is the Director of Multiple Myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai. Dr. Richter treats patients with plasma cell dyscrasias, including multiple myeloma and related diseases, such as AL amyloidosis, plasma cell leukemia, and Waldenstrom's macroglobulinemia. Dr. Richter has extensive experience with clinical trials focused on novel therapies, including antibody therapy and immunotherapy for a precision medicine approach. He has published extensively on these topics and is invited to speak regionally, nationally, and also internationally. He has been published in journals such as the New England Journal of Medicine, Blood, and the Journal of Clinical Oncology. So as you can see, he's well qualified, and we're super excited to have him here to share his opinion and thoughts on MRD.
Well, thank you. Hopefully people can see this, and hopefully you can hear me as well. I assume since nobody is awesome sauce. All right. Well, thank you, Audrey, for the very kind introduction, and thank everyone for tuning in. I will warn everyone ahead of time, I'm very opinionated about MRD, as almost everyone in the myeloma world is. Now, the main topic of how often should you get it while in remission, that's a very short and quick answer for the most part. So I figured I would walk through just MRD at a 10,000-foot view. At the end, kind of share my thoughts about when and how often, and then we'll open up to any and all questions. So what is minimal residual disease? And, you know, for those of you who are familiar with the term, you've probably seen this iceberg 1,000 times. You know, this notion that, you know, just our regular ways of evaluating myeloma, you know, in the blood, it can be 0, but we know that there's still disease underneath that we can only detect by bone marrow, and even routine bone marrow evaluation, where we just look under the microscope for the cells, may be inadequate, and there may be disease underneath that. So MRD, or minimal residual disease, is using new techniques. Oh my God, there's already questions coming in. All right, I will get to them at the end, I swear. Is really using new techniques to say how far down can we resolve the malignant cells, 1 in 1,000, 1 in 1,000,000, 1 in 10 million, and so on. So, you know, this notion of when you're diagnosed with myeloma, most people already have around 1 × 10 to the 12th malignant cells in them. And by routine evaluation, once you get down to about 1 × 10 to the 6th, you cannot detect myeloma in the body through the normal means, through blood, through standard bone marrow approaches. You don't see anything. And we know that there is still disease beneath that. And ultimately, our question is there a way to resolve this down to the point where we could say we've either eradicated all of it, or there's so few cells left they will never come back? And this is really where we start talking about our current limits of resolution. You know, we think back to the first person who was ever officially diagnosed with myeloma, Sarah Newberry, who was diagnosed in the 1840s. And for her, MRD negative was when she didn't have a visible plasmacytoma, right? They didn't have molecular testing, they didn't have SPEPs and things like that. Now, our line in the sand continues to get lower and lower. And right now, you know, what we're really dealing with is the current standard is 1 × 10 to the 5th, or 1 × 10 to the 6th, as that kind of borderline of saying if we don't detect cells beneath that, we call you MRD negative. And at least kind of the general way to think about it is that if we find 1 in 1,000 cells being malignant, that really equates to a complete remission. 1 in 10,000 cells, a stringent complete remission. 1 in 100,000 is where we start to get MRD by flow cytometry, or what we call NGF, next generation flow. And the 1 in a million is where we're talking about next generation sequencing. Now, the greater the depth correlates to your outcomes. So again, all of the studies that talk about MRD really only focus on a group of patients that are equally matched that all get the same treatment. So with this study and many like it are showing that people who achieve these different degrees of MRD negativity, we didn't adjust their therapy based on their MRD levels. We didn't give them more, give them less. But people receiving the same degree or type of therapy, when you get less than 10 to the minus 3, 10 to the minus 3 to 10 to the minus 5, or 10 to the minus 5 level of MRD, we see a dramatic difference in outcome in terms of survival. And one of the ways to think about it came out of this great paper about 7 years ago from Rostron and colleagues showing that for each log reduction in MRD assessed, or MRD that was detected, there was an approximate 1 year improvement in median overall survival. So 1 in 10 cells, 1 in 100, 1,000, 10,000, and so on really improves things. So the way we conceptualize risk nowadays in myeloma is through cytogenetics, FISH, and studies like that. But yet another way to think about it is to kind of wipe the slate clean. And, it's just a proof of principle. If we give you treatment and you have a deep response, you tend to do better. So how do we measure this? And there's different approaches depending upon what we're looking for. Are we looking for the malignant cell itself? Or are we looking for signs of the cells like what there's called circulating tumor DNA or circulating free DNA? So these are the remnants of when the cells break apart, and there's a variety of techniques like polymerase chain reaction, and PCR is something that COVID has kind of taught the world about. That is one of our techniques for finding small amounts of abnormal genetic material or abnormal proteins at a really, really tiny level. But the majority of techniques we use are looking for the cells themselves, using things like flow cytometry and FISH, and ultimately this concept of what they call macrofocal bone disease, combining different modalities and including your blood work. Do we detect any of the bad protein in the blood or the urine? A bone marrow biopsy, do we detect evidence of the bad cells or the DNA as remnants from the cells? And a third is incorporating our imaging techniques. Do we have an MRI or a PET CT showing no evidence of disease or resolution of disease? Now, right now, we really use the International Myeloma Working Group definitions, and these are the definitions that are laid out by the International Myeloma Working Group, of which I sit at the kiddie table, where the adults have, Thanksgiving dinner, and I sit in the corner with the kids, sneaking little sips of alcohol. That's kind of my position at the IMWG. But it's an amazing group of international collaborators who've established these definitions for MRD. And we have flow MRD negative, which is using next generation flow cytometry. We have sequencing, next generation sequencing, or NGS. But there's two others here that we incorporate. One on the bottom is imaging plus MRD negative. And we know that in general, myeloma cells really like to live inside the bone marrow. They like that niche of supporting cells. But we often have people that have what we call extramedullary disease that's outside the bone marrow, the bad cells that can survive outside of that comfort zone with the other supporting immune cells. And here, incorporating an MRD test, either an NGS or NGF, plus a PET scan or an MRI, really improves that. Because we have some patients that have lesions everywhere, but their bone marrow doesn't have a lot of disease. So MRD negative in the bone marrow doesn't mean the same thing for them as it does for other people. And what's probably the most important of all of them is this notion of sustained MRD negativity. So, we always talk about myeloma as a movie, not a picture. And the idea is that it's more important to have 2 MRD tests done over time, both being negative, says a lot more than just a single one. And, this kind of brings up this short answer of how often, and the definitions for sustained MRD negativity are two tests that are both negative at least 1 year apart. There's a lot of really interesting data that's coming out from a variety of studies about doing this more frequently, every 6 months and even every 3 months. But to the people who are designing studies to do bone marrows every 3 months, I asked them to recognize the literal pain in the backside that a bone marrow can be. And although we learn a ton from this, I think in routine clinical practice, doing a bone marrow every 3 months and even every 6 months is asking a huge amount for our patients without any clear guidelines just yet as to what that means or what to do with the information. So when we kind of take a step back, we look at NGF or next generation flow, NGS or next generation sequencing, and imaging studies. So next generation flow. Flow is available almost everywhere. You can do flow, I can do flow, they can do flow in the middle of the country, in the major cities, across the pond, everywhere you can do flow. And the benefit is that you can do it at anywhere, anytime. You do a bone marrow, you can send flow. It's applicable in the majority of patients. It's very, very sensitive for finding it. The problem is it suffers from a higher false negative rate. Plasma cells are designed not to die in our body. Once you put them in a flow cytometer, they crumble and fall apart. So the problem is if you take a flow cytometer and you put 3 cells in and you get 0 on the other end, you don't necessarily know that 0 went in on this end, because if you put 3 in and they fell apart, the patient is not really MRD negative, but because they don't make it and you get none on the other end, it appears as if they are. So even though this is a more utilitarian test, it does suffer from a general problem with flow cytometry of underestimating the number of bad cells, has a little bit of a higher false negative rate. NGS is a little more sensitive. It's staunchly in the 10 to the minus 6 level of detection. There's a couple of limitations. One is that it's only run by one company at the moment. Now, that's not necessarily a limitation. It's just the fact that there's only one company running it, but they're very accessible and they're great to work with. You need a baseline sample. So you have to have some marrow at the time of your original diagnosis or at some point in your disease when you had measurable disease to look for unique molecular signature to then look for later on to identify if you're MRD negative or positive. If you don't have that initial sample, you can't run the next sample. So you have to have a baseline. So if you've traveled all over the world and then end up in my clinic and say, I want to know if I'm MRD negative by next-gen sequencing, if I don't have your original marrow, I can't send it. Plus, about 5 to 10% of patients will not have a unique identifiable signature, meaning you send it at the time of diagnosis, but there's nothing unique about the plasma cells by this technology, so we can't look for that unique signature later on. And MRIs and PETs, they're much quicker and they give us evidence of macrofocal disease, but there's a resolution limitation. Unfortunately, people can have widespread myeloma that's still not quite detectable by PET or even MRI. So how is flow cytometry run? And this is just some rudimentary flow cytometry, and it's a lot of dots, but I'll explain. You'll see that each of these squares has a number going up and a number going to the side, and we call that forward scatter and side scatter. And let's take, for example, A. A has CD19 on the y-axis and CD56 on the x-axis. Now, I don't know if you're going to see my pointer. Do you guys see my pointer? Maybe? Yes, no? Oh, wait.
Yes,
Anna? Yes?
Like your mouse? Yes.
Yeah.
Yeah.
Awesome. So here's the midline of 56. Anything to the left means the cells are CD56 negative. Anything to the right means they're positive. Here's the midline of CD19. Everything above means they have CD19. Everything below means they don't. So the fact that there are all these cells here say that the majority of cells are CD56 negative and CD19 positive. And here is where we find these green ones are highlighted just the plasma cells. And then we take those and we look to see, does it express CD45? Nope, it's below the line. And we use these different colors of flow cytometry and we kind of isolate out the plasma cells and then we see where they land in the end, and it lets us know, do we have some or not? Now, this is unfortunately an example of what we would call an indeterminate. They find amidst a whole bunch of plasma cells, they find a couple of bad ones. We don't know if this means it's a true negative, a true positive, or really we can't tell. But basically, we run all these different markers to find the set of what we call the immunophenotype. CD56 positive, 19 negative, 117 negative, 38 positive, kappa or lambda, and we get this whole realm of these are all positive, these are all negative, and we isolate out the plasma cells, but potential problems. Here is next-gen sequencing. And again, you have to identify the signature when there is some measurable disease in the marrow. And if you don't identify it here, you won't be able to look for it later on. Now, in their study, they found 8% clone ID failure. And again, this kind of correlates to about the 5 to 10% of patients we know will not have a unique signature to look for later on. So it's one of the limitations. However, again, it's more sensitive than next-gen flow. Now, we recognize that there's two ways, two groups of evaluations of response. The standard model, PR, 50% reduction in your myeloma in the blood, VGPR, 90% or more reduction in CR, complete remission, means we do a marrow and we don't see malignant plasma cells. Now, we recognize that just achieving CR may not correlate with your MRD evaluation. Most people think of that PR, VGPR, CR, MRD positive, MRD negative, but it's actually not true. In fact, you can be a complete remission and MRD positive or negative. You can be less than a complete remission and MRD positive or negative. And here are all four of those possibilities. And ultimately, MRD negative is the better predictor of outcome than CR. Remember that MRD is a little more of a formalized thing. When we evaluate for complete remission in the marrow, we stain the bad cells and then we look at them. And that's all a little bit by eye. So for example, it's like looking at my screen and I ask you what percentage of the total screen is orange. And just looking at this area here, is this 2%, 1%? Is it just a rounding error? Is it 5%? And that's how CR is evaluated. So there can be discordance, and MRD seems to be the better predictor. And even when you have all patients as classically evaluated as complete remission, we can see here, even though small numbers, the difference in outcome, the difference in time to progression between the MRD negatives and MRD positives was 35 versus 131 months. So there can be big differences, even though on the surface they appear the same. Now, what does this mean in terms of our sensitivity? 10 to the minus fourth, fifth, sixth. And we see that kind of regardless of the depth of our analysis, MRD negative predicts for better outcome, and this increases as our sensitivity does. So the better outcomes in progression-free survival and overall survival come with better abilities to detect MRD negativity. What about it if we compare across different modalities? And here we have PCR, which generally isn't used that much. And MFC is multicolor flow. Think about it as, kind of the flow cytometry 1.0 version, and next generation flow is the better version, but it's another version of flow. And it's not quite as good, but any of these techniques are good. So if you are undergoing MRD testing at your institution and you want to know, do you have PCR, next-gen flow, next-gen sequencing, it at some level doesn't matter, because any evaluation of MRD will kind of give you that information. Yes, you get more granularity the more sensitive you are, but we see here that regardless of how sensitive or which technique, achieving MRD negativity does show improvements across the board. And does this mean anything for newly diagnosed patients, relapsed patients, newly diagnosed with a transplant, not a transplant? Again, kind of regardless of what your part in the journey is or what path you're taking, MRD negativity shows better outcomes. Now, is MRD negativity the end-all be-all? Absolutely not. There are people that never, ever achieve MRD negativity who can do better than everyone. And that's because when it comes to MRD, we're focusing just on the bad cells. What about the rest of it? What about the backdrop? Is this high-risk cytogenetic disease or standard-risk cytogenetic? we've learning a lot from a lot of our colleagues, including some phenomenal work being done by Bruno Paiva about reverting patients to an MGUS-like state. There are people that can get all types of treatment for myeloma, and at the end of the day, they're not MRD negative. They're not even MRD positive. They still have measurable disease. But the behavior, the biological behavior, that disease that's left over behaves like an MGUS. And we all kind of say that MGUS has about a 1% chance per year of progressing. There are people that can revert back that have disease that's quiescent. It's measurable, it's there, but it's not growing. And whether it's because of the biological nature of that residual disease or the rest of the immune system has recovered and that can hold it under control, or a combination of the two, there are people that can have residual disease, not MRD negative, that can do amazingly well and in some cases never relapse because their own immune system is holding a quiescent benign disease under control and it stays there. So it's not MRD or negative or bust, it's really a much bigger picture. So where are we going in the future? I think we can all agree that bone marrow biopsies are not fun. They're, we can do some of them. People are better than others at performing it. Sometimes they can be done under anesthesia, but it's a pain in the butt, both literally and figuratively. And the kind of holy grail of MRD assessment is in peripheral blood analysis. Is there a way we can look in your peripheral blood and correlate what we find there with the bone marrow? And there's a couple of really cool competing technologies that are probably going to answer this in the coming years. One of them, next generation sequencing. There's ongoing studies looking to see if NGS can be run in the blood. And remember, we have to correlate what we see in the blood within the bone marrow, so that's still being worked out. There's something called soluble BCMA. So a lot of people may talk about BCMA therapies like CAR T or bispecific antibodies or antibody drug conjugates like belantamab. BCMA is a marker that's on plasma cells. Well, guess what? Plasma cells shed that BCMA and it circulates in the blood. And there's ongoing studies looking to correlate the levels of the BCMA circulating in the blood as a marker of MRD negativity. And another really cool one coming out of the Mayo Clinic is mass spectrometry. And this uses different techniques to isolate the exact protein and say, well, is this, one of your medications? Is this your myeloma? Or what is that protein at very, very fine levels? A lot of great work coming out with those techniques and a couple others. So as kind of the final wrap-up slide, what are the big questions? So can MRD status be measured or monitored in the blood? And if so, what technique? Circulating free DNA, soluble BCMA, mass spec, we just don't know, but all of these are being actively researched as we speak. When should it be measured and how often? The kind of golden question. Well, to be honest, all that we've really learned to date definitively about MRD is if you take two groups of patients that are matched, age, comorbidities, disease, you give them identical therapy, and then half of them are MRD negative and half are MRD positive, and you look at the average remissions. The average remissions of the MRD negative patients will be longer than the patients who are MRD positive. The rest, we're not exactly sure. And those lead to the questions below. The how often, I think that the question is, what you're really going to do with that piece of information. I think if you really want to track your MRD negativity status while in remission, once a year is an appropriate course to do it in. However, what I tell my patients, a lot of them, is if they're in remission a year or 2, 3 out, and they're on maintenance, and the general plan until we know better is to keep them on maintenance, I say, I can do a bone marrow in you. And if it's MRD negative, you're going to go, yay, and we're going to continue what we're doing. And if it's MRD positive, you're going to be upset, and we're going to continue what we're doing. So I'm still not ready to adapt this as everyone gets it all the time, but it's an ongoing question, ongoing data and discussion with your care team. So if you do not achieve MRD negativity status with a given therapy, should you give more therapy to change that? And we don't know that answer. In ALL, a different disease, we know that if you take two groups of patients and one gets MRD negative and the other does not, we can give that group more therapy to convert them to negative, and they will do better. This has never been proven in myeloma, there was an older study before MRD that looked at complete remission, and it gave groups of patients identical treatment. Group A got complete remission, Group B did not. They gave Group B more therapy to convert them to complete remission, and they still did not do as well as the patients who got MRD negative up front. Because again, how you get there means something as much, if not more, than just getting there. But the question is, if you get MRD negative with induction, do you still need a transplant? If you don't get there after transplant, do you need a post-transplant consolidation or a CAR T? Still figuring this out. If you achieve sustained MRD negativity in the maintenance setting, so if you have 2 studies a year apart that are negative, can you stop maintenance? If you have 3 apart, can you stop? 4, 5? We don't know. What if you go from MRD negative to positive? Should you reinitiate or change your treatment? I have a woman who was MRD negative for years, and 2 years ago, her bone marrow converted from MRD negative to positive. No measurable protein in the blood or the urine or on PET scan. To date, I have done nothing, and she remains in complete remission, no measurable disease in the blood, urine, or on imaging, and MRD positive. So just because you switch from negative to positive doesn't mean you've done anything. And remember, even below MRD negative, there's still disease. So if this is the line in the sand, and day 1 you're here and it's negative, and day 2 you're here and you're positive, you've had no real change. There's a difference between going from this to this. This to this is just some minor variation. And what we're starting to learn from a lot of trials is your cytogenetics matter. That it seems from some of the data from the master trial that people with 0 or 1 high-risk cytogenetic abnormalities will likely behave different than 2 or more high-risk cytogenetic abnormalities in terms of long-term outcomes and in terms of MRD-driven decision-making. And the kind of brass ring, is there a certain depth or duration of MRD negativity that we can equate to cure? For example, maybe it's that it has to be 10 to the minus 7 sustained over 3 years. And if you achieve that, you're cured. We don't know, but that's the hope. And with that, I will thank you, and we can go on to as many questions as you'd like.
That was fascinating, Dr. Richter. Thank you so much for such a great presentation. I really do appreciate you taking that time to prepare. There's a lot of great questions, as you can see, and I think it's going to form a great discussion for us today. One of the commonly asked questions in the box right now is regarding patchy bone marrow. So we know that myeloma obviously is in the blood, bone marrow, and how do we trust the sample that's given? For example, one of the patients here said that at one institution, they got a 40% result, in the other institution, they got a 20% result. I mean, with a disease like myeloma, how do we handle that, or how do we trust the accuracy of the MRD test?
So that's a phenomenal question. And that's one of the problems with MRD testing, is that there's variability. It's, yes, you can have 40% here and 0% there. There's user variability. I think everyone out there can talk about the bone marrow that went so deep, they felt it a week later, but sometimes the marrow that felt the best only got a tiny sample and it may not be representative. And again, one of the ways to kind of offset whatever variation this is to follow it over time, because that increases the number of looks into the marrow. In days past, for other diseases, not necessarily myeloma, but for Hodgkin's disease and small cell lung cancer, the patchiness actually led the standard of care to be bilateral bone marrows at the time of diagnosis to get over the variability. So there was a time where I had seen a Hodgkin's patient at the VA many years ago where we did bilateral marrows on them because you wanted to account for that. Not suggesting we do bilateral marrows, but that's why some of the peripheral blood testing is a really good notion, because the blood is kind of the end result of all of the marrow at some level. Right. So I think long-term peripheral blood is going to be the answer for a lot of reasons.
Interesting. Yeah. And hopefully less painful. I mean, obviously less painful. Let's talk about why would specialists, I have several patients in the questions right now saying, I'm in current remission with, no sign of disease, but my doctor is still saying they're not supportive of me receiving an MRD test. Why would this be? Give us some insight into why this would be. And then if you don't mind sharing your own personal take on if you try to get your patients to MRD negativity.
Yeah, I mean, so, one of the things about MRD negativity is a lot of physicians are talking about it as a goalpost, but it really is not the end all be all. And I think before the broadcast, you and I were talking about this, and I can share with the group, there's a kind of slippery slope thought experiment about why achieving MRD may not be the end all be all. So imagine a patient who gets VRD up front and doesn't get MRD negative, and you say, this is not good enough. Let's give them carfilzomib Pomdex. And you give that to them, and they still don't get MRD negative. And you give them Daraselinexor, and they still don't get it. Then you give them belantamab and Carvicti and Abecma. You give them all the therapies, and there's still detectable disease. There's no evidence that that person who's had 15 treatments and is not MRD negative is any different than that VRD person who didn't get MRD negative. The only difference is you've now exposed the cells to all of those treatments. So I think
And
part of
therefore
this
shorten their lifespan.
potentially shortening their lifespan, and I've known of physicians who have patients who had sequential MRD testing and who went from 10 detectable cells to 100 detectable cells, still had no measurable disease anywhere, imaging or blood, and that physician changed their therapy. And I don't think that's the right way to do it. What we know from going negative to positive is if you have two groups, and group one goes from negative to negative, and group two goes from negative to positive, the average time to relapse will be shorter in this group. But shorter means what? 3 months versus 6, 5 years versus 10? We don't know that. So I think a lot of the reticence for care teams doing it is we really don't know what to do with the information.
Yeah, yeah. Two questions to follow up with that. Does it affect overall survival? I mean, we've talked about progression-free survival. We know that it's longer. Overall survival, what does it have to do with overall survival? And then I'll ask you that, and then I'll ask you my question.
Yeah, it does. Achieving MRD negativity does correlate to overall survival, but we conceptualize that on the end of the treatment itself. So we gave treatment X and you achieved MRD negativity. But a better way to think about it, or another way to think about it, is it more relates to the sensitivity of the myeloma cell that allowed that to happen. So again, if you hold a bottle of Revlimid in the room and you get MRD negativity, that's a different concept than giving somebody DARA, RVD, transplant, auto, allo, CAR T, and then getting MRD negativity. So yes, it does affect overall survival when you give two people the same exact treatment and one group gets there and the other doesn't. They will have an overall survival advantage. But we need to take a step back and understand what it means as a sensitivity marker of the cells themselves.
Okay, that makes sense. Thank you. Another question that I thought was interesting, and I've never thought about this before. Where are the myeloma cells hiding? I mean, we talk about patching bone marrow. Is it just randomly in the bone marrow where they're not able to, test it? Or where would you say they're hiding in these tests?
So in an adult, the majority or the lion's share of marrow is in the sternum and in the pelvis, which is why bone marrows are done in the pelvis, and there are people who've had them in the sternum. But there's bone marrow everywhere. There's bone marrow in your jaw. There's bone marrow in the bones in your fingers, and we don't test for all of that, and we really can't do that. So the patchiness is real. So even in the hip, you could have been a millimeter away from a small patch of cells that are just existing. So because we can't sample the entire bone marrow, they are just hiding in another spot in that space.
Interesting. It shows how complicated this topic really is, because while it's great technology, and you think, so that was going to be my follow-up question there, was how many years out do you think we are from getting these answers that we're searching for?
So I think the next 2 to 5 years are going to give us the first steps towards answers. The big questions that we're asking, if you achieve sustained MRD negativity in the maintenance setting, can you stop? I think that's one of the biggest questions that people are asking, because
and that's
right
being
now,
tested, right?
And one of the studies, like the MASTER study, has looked into this, but the relapse rates are different from people with 0 or 1 high-risk cytogenetic abnormality versus 2 or more. And even those with 0 and 1, the relapse rate is not 0. There are still people with disease coming back, and their average follow-up is only a little over a year, year and a half. So we just need more time on the plate to know what level of MRD and what number of sustained MRDs equals what? And is it the same if you're high risk or standard risk or ultra high risk? And I think the next 2 to 5 years are going to be the first steps to that. And beyond that, I think we're going to start having better data on peripheral blood tests to follow these things and get some of those answers.
Interesting. I have a couple non-secretors in the audience right now. Do you recommend MRD testing for non-secretors more frequently than you would, or suggest it for regular patients that can, see their M spike?
It's a great question. I think it depends upon the nature of the non-secretors. So some non-secretors have plasmacytomas or lesions that are measurable by PET or CAT scan or MRI. And for those patients, I think regular imaging is better than invasive bone marrows. And especially for younger patients, I get more frequent MRIs because MRIs are magnets. There's no radiation. I follow some 20 and 30-year-olds that I don't want to do a CAT scan with radiation every 3 to 6 months for 40 years. That's not a thing to do. So I get more MRIs. We have some patients. I have a patient who non-secretes, just fills up the bone marrow. PET's negative, but they just go cytopenic, needs more regular marrows. For those people, the next generation is going to be soluble BCMA, because it turns out this soluble BCMA that gets shed from the plasma cells even comes out in non-secretors. So this is not quite ready for prime time. In the next couple of years, this may get to be a certified test where you can measure this, and it doesn't matter if you're IgG, IgA, kappa, lambda, or non-secretor, everyone secretes BCMA, and that might be the new way to monitor even the non-secretors.
Yeah, that's fascinating. Thank you. We have another small population of 1114 translocators out there. And it's been recently said by Dr. Guido Tricot that with his experience, 1114 patients were really hard to get to that MRD negative state, but in the end, it didn't matter because they were able to live with stable disease and live long lives that were healthy. Has your experience been the same with that genetic population?
So, part of it is, that these studies are fascinating, but again, a lot of this is in isolation.
Mm-hmm.
Part of the 1114 experience also is what other cytogenetic abnormalities are along for the ride.
Mm-hmm.
So having an 1114 in and of itself is not only a good prognostic factor, but a lot of those patients will do very well with a drug like venetoclax. But you can then start parsing out people of 1114 that also have a 1Q amplification, and that subgroup will do worse than 1114 without a 1Q. And even 1Q, it matters, do you have 3 copies, 4 copies, 6 copies? So it's getting ultra granular. And the other part of that is when we talk about this stuff, that's looking at just what we call genomics. And in our institution, one of the things that we're working on, and Dr. Trico and many others are looking at this as well, we call multiomics, proteomics, genomics, immunologics. So basically, not just the genetic abnormalities, but what are the proteins that are being made? What are the genes that are turned on? What are the NK cells, T cells, and other non-myeloma immune cells? Are they upregulated, downregulated? Are they fighting the myeloma? And trying to put that together in one complete package. So, the hope is that we're able to put this all together in the not too distant future and then give you the computer splits out the planet care.
That is fascinating, but wow, if myeloma wasn't already complicated enough, basic myeloma, that's exciting, but also crazy. Gretchen's asking a really good question. Are we able to identify residual cells that you were talking about earlier that behave like MGUS? Are we able to identify like, oh, this cell's going to be more like an MGUS cell than others?
So we're just on the precipice of doing that, and it's being done only in the lab right now by people like Bruno Paiva and a few others. So that's the kind of hope that at the end of whatever induction we pick, we can analyze the multi-omic version of this. What are your B cells, T cells, NK cells? What are those looking like? What is the cancer cell looking like? And how is this going to behave? That's one of the hopes in the not too distant future, but it's just not ready for prime time. It's only in the lab.
Okay, interesting. There's so many great questions here. A couple patients are asking, so I'll ask you, are you able to do telehealth visits, Dr. Richter?
All the time.
Okay.
The only limitation is, and this is a frustrating one, and I will have to reserve my frustration with this. States have different laws.
Yeah.
So even though laws differ from state to state, medicine does not. Velcade is Velcade in New York, New Jersey, Alaska, Hawaii. It's the same drug. However, the United States has set up a state licensure, and during the height of COVID, everyone kind of let things go. But with COVID rates going down, states are cracking down on this. They're calling, depending upon what the state is, sometimes there's reciprocity. Sometimes the state will call it practicing medicine without a license in that state. So I recently saw a patient from Texas who had to fly in because the Texas Department of Health said, even if I just chat over the phone, they would call that practicing in Texas without a license.
Oh my
So
gosh.
they can always reach out and we can figure out state by state.
Yeah. Oh my goodness. Okay. Well, I'll refer them to you and then hopefully they can work something out. That's so crazy. And there is financial assistance as well. If you do want to seek a second opinion with Dr. Richter, there is financial assistance for flights. So we
Yeah,
can
and
get that information.
along those lines, listen, I will see absolutely. I love seeing patients. I love doing everything I can. Whether it's whoever it is, we know that people like the people who are engaged in this program. Being seen by any myeloma center, you will improve your outcome. So, I'm more than happy to see you. But if you live in Wisconsin, go to the Medical College of Wisconsin. There are amazing people there. Reaching out to people like HealthTree, Myeloma Crowd, MMRF, IMF to find a close site, because that allows not only for maybe a shorter plane flight or even a car ride, but should you need a clinical trial or other therapy, it's someplace you can get to. So absolutely be seen at a myeloma center. I'm biased. I think mine's the best, but there are amazing ones all over the country.
Yeah, we'll make sure to include that myeloma specialist directory in our follow-up email so that they have access to that. Great point. Thank you. I see several questions here about Medicare. From my understanding, Medicare does cover the next generation sequencing test. Is that true with your patients?
I am lucky enough to practice in a large institution bubble that somebody else deals with that part of it.
That's what I thought.
But a lot of the places that run these next generation sequencing tests recognize that they're in the kind of gray area in a lot of places. So there's a lot of ways around it, of forgiving the cost, ignoring the cost, only taking whatever insurance gives them. I mean, I think it's worthwhile to always have a discussion before bone marrow what's being sent,
Yeah.
because unfortunately we've all had patients that have had this horrible thing where we send 10 tests and they get a bill for an ungodly amount of money, and then we need to figure it out on the back end. So asking your team what's being sent and if it's covered is a great thing.
Yeah, totally. Make sure to consult with your team. And we're actually having a session tonight in the SoCal Myeloma Community Chapter. clonoSEQ, the adaptive NGS testing, clonoSEQ, they're coming to discuss. So if you have specific questions about that clonoSEQ test, you could come to our session tonight to ask. So now I guess the next big question is maintenance therapy, regarding maintenance therapy with MRD negative results, excuse me. As we know, patients are frustrated when they have MRD negative results, but they're continued on maintenance therapy. What do you do? What's your practice and opinion on this?
So what I tell patients is the following. I don't know the answer just yet. I don't think anyone knows the answer. I think that if you're on maintenance and you're not tolerating therapy, regardless if you're MRD negative or positive, and we've tried dose adjustment, supportive care, and you're not tolerating it, stop it. If you're not having any problems, continue it. What does MRD negativity mean in the maintenance setting? My guess is that for people with standard risk disease who achieve sustained MRD negativity, there's a high likelihood that a large number of those patients will do just as well staying on treatment or not. But we just don't know yet. And it's not always as black and white as high risk or standard risk. There may be a profile of patients who can stop and who cannot stop. So my current thinking is, until I know who is going to do just as well, I continue people on maintenance as long as it's working and as long as they're tolerating it. And a lot of this comes from studies that we've done, including the stamina study, which compared people getting 2 years of fixed duration maintenance or continuing until progression or intolerability. Those who continue do better. Are there a group in there that probably could have stopped? Absolutely. And as soon as I know definitively who that is,
That
I will
is.
stop those people, but not before then.
Yeah, it's so, yeah, that's interesting. Thank you for sharing that. So you mentioned that one of the reasons why you don't want to give MRD testing is to not stick that needle, to be a pain in the bum. I'm such a mom. But we have a patient that's wondering, do you ever do bone marrow biopsies and not send for an MRD? Why wouldn't you, if you're already in there, try to assess MRD for those patients?
Um, well, I think the question is it's the setting that you're doing a bone marrow. So there's a few key settings where we do bone marrows. One is to assess for MRD. And if we're doing it, then we definitely send it. If we're doing it at the time of diagnosis or relapse, and we're doing it to look at the genetics and genomics and a lot of other things, there's no reason to send it because it's going to be positive because we know the patient's relapsing.
Right.
And if it's negative, we know that it's a false negative. The other time we do them is if someone has unexplained low blood counts, because low blood counts in a myeloma patient could be a side effect of treatment. They could be a non secretory relapse that the myeloma is growing but not making a protein, or MDS, myelodysplastic syndrome, which is another abnormality. And there's other things it can be as well. In that setting, I send MRD negativity as long as we're there because we're not exactly looking for low burden, but they're likely to be a low burden. So that'll give us a little bit extra piece of information. So to that point, it's kind of like, if a surgeon is doing an operation on your colon and they'll sometimes take the gallbladder out because they're there anyway, that's kind of, yeah, if you're already looking in a low disease state, I'll send it anyway. But the other two, I don't send it because if it's negative, it means nothing.
Yeah, that makes sense to me. Thank you. We got several comments back from your stance on maintenance therapy, which is fine. I think the beauty of myeloma at this point is that there are tests going on. We're constantly learning, we're constantly growing and evolving. And so I think it's easy for me to say as not a myeloma patient, but there truly is no better time to be diagnosed with myeloma because of the amazing progress that's being made in this field. So, if people disagree or are reasonably upset with having to continue maintenance therapy, I think it makes at least there's hope on the horizon that specialists are aware of this and that things are being done in the clinical trial setting. Do you know what I mean? I don't know. Maybe
Yeah, no. This is the concept of MRD we're talking about in relative terms. Ultimately, all of these decisions about continuing or not, tolerance or not, are really an individual discussion with your care team. Everything I say from a Tylenol to a transplant has risks and benefits. And although we're talking about it in generic terms, there are granularities that apply to an individual. For example, if you're on Revlimid maintenance and there's a financial toxicity to that, that needs to be incorporated. There are, do you feel 80% of as good as you would otherwise? And are you fine feeling 80% is good? Is it okay to feel 100% and maybe there's a slight difference in outcome? And these are the individual discussions you need to have with your care team.
Yeah, definitely. Definitely. And that's kind of what you were saying earlier. So important to be seen by a myeloma specialist. So important to have an involved care team and also be involved in your care. I mean, myeloma, it is great that all this research is being done, but you also need to, be involved, which all of you here today are. So that is great and wonderful. And we're glad you're here. Cindy's asking an interesting question about kind of that patchy myeloma, trying to figure out where the best place to be. Why don't we take why wouldn't you take a PET scan to see where lesions are and then try to get where the lesions are? Do you know what I'm saying? Is that an option?
No, so we've done that, and we do that, but in a sense of knowing how to treat. And the reason is when we talk about myeloma in an individual, we know that it's not one disease even within one patient. there's usually around 4 to 6 subclones, and they may look very different genomically and may behave very different. And we've had patients that we give them therapy and they have a couple of extra hotspots, and we specifically biopsy them, and it turns out they have a feature like an 1114 translocation or a genetic abnormality that we can target. The notion of doing it for MRD testing, of saying, well, let's do a PET and let's biopsy the hottest spot, and if that's negative, that has a big meaning. It's a wonderful idea. The issue is one of accessibility. Bone marrow is a procedure we can all do in our clinic, and it's very accessible. What if it's one vertebral lesion that's really close to the spinal cord? That's a lot more invasive. I think the notion of that is a wonderful one. If the worst spot is negative, that's great. But then at the same time, if the worst spot is negative, do you really believe that it's negative, or could it be a false negative?
Right.
So a lot more comes into play, but I think it's a really great thought experiment, and there may be a way to incorporate that into some of our approaches.
Interesting. Yeah, I loved her comment there. So this is brought up by a couple patients as well. In the trials that you were explaining where progression-free survival was different with MRD negative versus positive, to what extent, what test was used, and how deep did they go with that MRD negativity?
And that's the biggest problem with MRD, is that trial to trial, the technologies, the depth, it differs in all of them. And that's, one of the biggest issues is that there's no consensus. Some of these trials used NGF, an NGS to 10 to the minus fifth. Some use it to 10 to the sixth, some 10 to the fourth. And did you do it at the end of induction, right after transplant? And the other question is user variability. There's so many features of it that can differ. So whoever brought that up is hitting the nail on the head. This is something that's a hot topic, and as a myeloma community, we need to agree on some consensus. The problem is by the time everyone can quasi-agree, the technology changes.
Advanced, yeah.
So this came up at an international myeloma workshop meeting a couple of years back when they were in person, and someone made a comment about how we need to change these definitions and get them standardized. And someone very intelligent, and I honestly can't remember who it was, stood up and said, well, you've had some studies that have already been going on for 6 years. If you change all the definitions, what do you do with all of that data? Is that now meaningless? So so it affects the trials that are already ongoing that you can't necessarily go back and reevaluate and make determinations from. So we have to find a balance. And I've spoken to some of the muckety mucks, the high up at IMW, and they've emphasized this, a balance between changing the guidelines and consensus on a regular basis versus changing it every 5 minutes versus keeping up with the technology. It's a lot to balance.
Yeah, it definitely is. And I didn't even think about it. It's almost like we need to start, saying clearly, I'm MRD negative and was tested with the 10 to the negative 4. Just to make sure we're all on the same page. Oh,
absolutely.
Goodness. It's crazy. Wow, this has been a really great discussion. I think our audience is very educated, and it's been really exciting.
They're asking the tough questions.
They are. They went straight for the throat. We'll finish with this question because it kind of leads into our topic for next month or 2 months from now. But would you use MRD status post-induction to inform your decisions on whether or not somebody needs a transplant right away, delayed transplant, or go to a clinical trial as an alternative to transplant?
Great question. No. And part of that is right now the myeloma world is getting separated into those who still believe in transplant and those who do not. And I will admit my bias. I'm still a believer in transplant because you never do worse with a transplant. There are just a small subset of people who don't do better. And we have to remember that MRD is an artificial line in the sand that gets lower over time, and myeloma is a biological entity. And that I have transplanted MRD negative patients, and the likelihood is that even though I couldn't see it, they went from MRD negative here to MRD negative there. There are more gradations below zero that we can't see. So if you tell your treatment team you don't want a transplant, you don't get a transplant. If you're on board with the fact that some people will get an extra day, some an extra week, some an extra month, a year, some an extra 10 years out of transplant, and we don't necessarily know who that is up front, then you go along with it. I've done MRD testing to have a discussion with patient to say if we're on the fence, there's better data to support that MRD positive patients benefit more than MRD negative, but that doesn't mean that MRD negative doesn't. So I'm a big believer in transplant because it's a different mechanism of cell kill. We know the deeper remission you are at every stage correlates to more durable remissions. And there's never been a study to say you do worse. We just don't know how much better you would do. And I say, if you look at all the transplant studies, there's that tail on the curve of people who have these unbelievably long remissions. So the short answer is I don't use that as a baseline. I have the discussion ahead of time. If the patient wants to involve that as a discussion for them, we can do that.
Right. Awesome. Thank you so much, Dr. Richter. The compliments are pouring in with just how much people loved you today.
Oh, shucks.
We'll have to have you back soon. Thank you.
Anytime.
Thank you so much. We're going to end with just a couple of outro announcements, and then we'll be done for today. So this chapter meets every other month. So we'll be meeting again in June as we discuss another commonly asked question in myeloma regarding MRD negativity that we kind of reached today was what to do with the result. I guess MRD negativity, positive, whatever, whichever, I mean. When should you change or start treatments based on your MRD results? Should an MRD positive test always result in intense testing to become MRD negative? We talked about that a little bit today. Should someone who is slowly coming out of remission be treated immediately? We're going to invite another specialist to come back and discuss their opinion with you on this subject, and you will be notified when the event is available to register for. I love these discussions, and I thank you for bringing your educated questions today so that we were able to have such a great discussion. It really means a lot to me as a moderator to be able to bring a great discussion to so many people today. Tonight at 6:30 p.m. Pacific, so that's, I believe, 9:30, 10:30 p.m. Eastern time. My time zones are all mixed up now. It's 9:30. Is SoCal Myeloma Community Chapter. We're again going to be talking about MRD, minimal residual disease with adaptive biotechnologies, about their clonoSEQ test, which is next generation sequencing. Then the 13th at 1 p.m. is the Connect with the Myeloma Crowd chapter. We're going to be talking about the search for diversity, equity, and inclusion with the HealthTree Foundation. We've launched a new African American myeloma initiative, and Marsha Calloway Campbell, who leads that, is going to be speaking to us. The 14th at 6:30 p.m. Eastern is the Northeast Myeloma Community Chapter. If you're living anywhere from Maine to Pennsylvania, you're welcome to join us for that. That's living with myeloma without defining yourself by it. It's going to be a leaded group discussion by a couple of the myeloma patients in the group. The link to sign up for any of those events and even more events I did not mention today is found at the bottom of this slide and will be sent out in the follow-up email within 48 hours of the event's conclusion. As always, I'd like to thank our sponsors without whom this would not be possible: Bristol Myers Squibb, GSK, Genentech, Janssen Oncology, and AbbVie. And thank you to each of you again for being here today, helping us build a strong myeloma crowd community. I appreciate you and hope you have a great rest of your day. Thank you all.